who's planning to come to arrive, and then we'll get cracking. Okay, I think we should get started in the interest of time, because we only have an hour. So thank you so much to everybody that is attending this prostate cancer webinar. I am Lucy, I'm a GP, and I'm also the primary care cancer lead for North West London. And I'm going to be opening this meeting and then handing over to our excellent panel who have very kindly attended today. So as you can see, the agenda that was just up a moment ago, and if you wouldn't mind just making sure that we've got some good housekeeping in terms of, if you can have your camera on, it just makes it so much nicer for the people that are presenting. Any questions that need answering can go into the chat box, and there will be opportunity for questions at the end. And if everybody can just have their microphones on mute, that would be fantastic. So the aim of this session is to essentially understand from a patient's point of view the realities of having a diagnosis of prostate cancer. Then we're going to move on to understanding prostate cancer a little more, the risk factors, and how primary care can really engage with our highest risk populations in terms of diagnostics. And finally, we'll be closing with some updates in terms of changes to the diagnostic pathways, PSA testing, and I suppose the patient pathways that they will be going through. So I will hand over to our first guest, who is Jeff. So Jeff, over to you, and thank you so much for coming.
Jeff, you're on mute. Oh.
That's right. Can you hear me now?
We can.
You can. Right. Fantastic technology, eh? Right. Let me go right straight into it. Yeah. Well, I was diagnosed with prostate cancer in 2018, and I'm one of those cancer patients that had no symptoms whatsoever. So upon entering a conversation with a friend of mine who I used to spar with, he then told me that, I hadn't seen him for 3 weeks. He told me he had prostate cancer. He told me about the procedure that he went through, where he had to go and get a PSA blood test. And then from the PSA blood test, certain things were highlighted, that later on he was then diagnosed with prostate cancer. Upon hearing him tell his story to me, I thought to myself, I need to go and get myself checked also. But even though I see myself as physically fit and constantly moving, I went to my doctor's literally the next day, and I said I wanted a PSA blood test. Now, when I got to the doctor, it was the look that he gave me at first was almost like I was asking him for money. I would like to have a PSA blood test. He looked at me and said, "Why do you want a PSA blood test?" And I didn't know what to say at the time because this was all relatively new for me. So can you all hear me? Yeah. So I then said to him, "Look, I believe I'm entitled to this blood test." However, eventually he gave me the PSA blood test, which I thought was, okay. Just the needle and blood being removed. But then he asked me if I wanted a DRE performed, which I didn't know anything about this DRE. To be totally honest, I've not said it before. When everyone said to me DRE, I think of Dr. Dre. So it had nothing to do with, what he said it was. Now, at that point, when he described doing a DRE, I became extremely tense, in certain areas. Buttocks tightened up, and if I walked, I would have squeaked. Yeah, so he then said to me, it's a quick procedure. I looked at the size of his fingers, and I thought, oh my God, that's going to go somewhere the sun doesn't shine. Now, I resumed the position that he asked me to get into. And again, I seized up. And because I just wasn't relaxed, I wasn't comfortable. And in the back of my mind, I was thinking, is this really a procedure that has to be done? Can I not opt out of this procedure? But I'd be totally honest, I literally felt bullied into having that procedure done. Yeah, but the reason was I felt my doctor wasn't actually, let's say, empathetic enough, listening to what I was going through, the anxieties I was going through, and this was all just too much for me at the time. Anyway, however, he performed the procedure, and then he used this word, oops. So when he said oops, I thought he had probably damaged something. But no, he said oops because the prostate, he said, was lumpy. That gave me cause of concern. I then said to him at that time, what are the symptoms generally that one will get from having prostate cancer? Because I had no symptoms whatsoever. He quickly ran through and said, well, frequency going to the toilet, may have blood in the semen or in the urine and so on. I thought, okay, fair enough. But you know what? I remember I used to have lower back pains. Yeah, and I kept going to my doctor and complaining about the lower back pains. He then said to me, it's because of the amount of physical exercise I'm doing. I was then sent to physiotherapy, okay, on frequent basis. And every time I went to physiotherapy, this back pain was not going. It's only after I was then diagnosed, right, with prostate cancer, I was told that one of the symptoms was lower back pain. If I told you guys how long I've been complaining about this lower back pain, you'd be surprised. It's not a year or 2 years, it's been years. Yeah, and because of my physical activity, it was put down to that. But then it was the sign that something was happening. I then found out that's one of the signs of having prostate cancer. The anxieties that from then that built up just by feeling no disrespect, feeling that my doctor wasn't totally on board with the symptoms and the fact that I came in there and he asked me, why do you want to have a blood test? It wasn't queued up that, the fact that 1 in 4 of us Black men will have prostate cancer. And it's almost, I felt that was the beginning of a bad journey for me. Yeah, not having things explained to me properly. Yeah, I felt like I was in a conveyor belt. It's like a rush thing. Come on, next. Okay, we'll move on to this step. So it went as far as leading up to my the options that I decided to have my prostate removed. That again, when I was told I had prostate cancer, you could give me any information. You could take all the money that I have. It wouldn't matter because I wasn't hearing you. It was just white noise. So psychologically, I had a terrible effect just hearing that word, you got prostate cancer. And I just felt to myself that if I was guided a little bit more, and given a little bit more information from those that I trust, I think it would have been a little bit easier for me to deal with, the long-term situation, because I'll be straight with your From there, when I was diagnosed with prostate cancer, after having the operation, I decided to try and commit suicide because everything was just too much for me. So, I feel it's important that, doctors tend to understand that every time a man steps into your office and we're worried about cancer, be it prostate cancer or cancer, we are already living a trauma. We are already in that state of fear. We are already in that state filled with anxieties. Because we don't want to hear. Reassured in the presence of our doctor, it's really important. And the first time, I'll be honest with you, at that point, I actually got turned away the first appointment I made. Yeah, as if I wasn't eligible. But following suit, I was then diagnosed with prostate cancer, and the journey was tough. I must say, it was very tough. But I'm here, still standing, and still focused, and just out there pushing the awareness of prostate cancer to our community and encouraging our men, to be strong, have a lot of tenacity, and also let them know that prostate cancer is not a death sentence. I think I'll end there. Thank you.
Jeff, thank you so much. I think you can see from the endorsement there that's going on from the people that you can see on the screen how appreciated that was. From a personal point of view, it's so powerful to hear people's stories outside of the clinical room, and really helps us to focus on how important our work is and how life-changing it can be to people like you. So thank you so much for coming and sharing your story. It means a huge amount to us. So thank you for that. And it sounds like you're doing some amazing work in terms of raising awareness, and hopefully with our help, we can do that too. So I will now move on. So thank you, Jeff, to Timer, who is here to speak about the kind of prevalence of prostate cancer and to give us some kind of clinical guidance. So thank you so much. I'll hand over to you.
Hi, good afternoon. Not sure how I follow Jeff, but I'll try and give you an overview on a little bit about prostate cancer, particularly from a clinical perspective. My name's Tamer Shah. I'm one of the urologists at Imperial. I deal predominantly with prostate cancer in my clinical practice. And I think many of us are probably aware about this already. Prostate cancer is one of the leading causes of death amongst men. It's second to lung cancer, but it's actually the most common cancer in men. And we diagnose over 50,000 cases a year. And about 12,000 men die from prostate cancer every year. And actually, what this means is that more men are dying from prostate cancer than women are from breast cancer. And at any given time, there are about 180,000 men in the UK who are living with prostate cancer or living after a diagnosis and having had treatment. Next slide, please. And this slide highlights that although we do see prostate cancer in young men, it does happen. We do see it in those particularly with risk factors from about 45 onwards, and there are some in their 50s. It's generally a disease of slightly older men. And this is reflected by these mortality curves where a lot of the deaths happen in those that are over 60 and over 70. But it also emphasizes some of the lead time we have. So even after a diagnosis of prostate cancer, many men will live at least a decade, particularly with localized disease, if not longer, after having had that diagnosis made. So we also have, it reflects some of the good outcomes we see with treatment. Next slide, please. And this is our own local data. So and it's this pre-COVID, a lot of this data, and I've got some data coming on the next slide, what's happened after COVID, but up to about 2020, over a 10-year period, we diagnosed 15,000 cases. In the 5 years just before the pandemic, we'd actually diagnosed 9,000. So the trajectory was up in terms of number of diagnoses, and approximately 1,000 men had died from it. And the projections show that this prevalence of disease should increase steadily, probably by at least about 6% over the next year or so. Next slide. And this slide shows the number of new referrals we were taking in secondary care for suspected prostate cancer. And I think we can clearly see at the beginning of the graph, so on the left-hand side, there was a very sharp drop when the pandemic started. So we were averaging somewhere between 1,000 to 1,200 referrals a month as a region, and that basically nosedived. And it didn't really ever catch up for probably quite a long time. And it wasn't until probably last year that we were starting to see referrals pick up to the levels that they were pre-pandemic. And recently, the general trend is that we're probably now diagnosing more patients. So we're getting more referrals for suspected prostate cancer than we were prior to the pandemic. So probably in the region of between 1,200 and 1,400 a month. So a lot of the work around raising awareness is probably having an impact, but we've still got quite a long way to go to try and catch up on all the men that we didn't find during the pandemic. Next slide, please. And I think I'm now handing over to actually Lubna to talk a little bit about the risk factors and some of the work that's being done.
Thanks, Dr. Shah. And just to introduce myself, my name's Lubna Latif Curtis. I work for Prostate Cancer UK, and I'm one of the health influencing senior officers here within the charity. So as Dr. Shah has said, I'm going to talk to you about some of the prostate cancer risks, and you can see here that there are 3 categories of risk to prostate cancer. The first one is ethnicity. So as Jeff has already mentioned, 1 in 4 Black men will get prostate cancer in their lifetime. And that's a shocking figure. And that's the reason why it's fantastic that people like Jeff, and also I can see Errol here on the call, hi Errol, are happy to come and share their experiences to be able to shift that dial and start getting these conversations started. What we also know is that for 1 in 8 non-Black men, they will also be diagnosed. So again, it's high prevalence rates. And then for Asian men, it's 1 in 13. So it's really important that we think of ethnicity when we think about prostate cancer. As we know, age is a risk factor as well, but interestingly for Black men, the age should start to be considered from 45 onwards. What we know is that Black men are more likely to be diagnosed at a younger age, and curiously, there's still research going on as to why this is happening. It is with a more aggressive, that means a faster growing disease. And then the next cohort of men who should be targeted are all men who are over the age of 50. Family history, as we will know, is always a risk factor, and if your father or brother have had prostate cancer, then incredibly you're 2.5 times at greater risk. And then we would also ask you to consider a family history of breast and ovarian cancer because of the presence of the BRCA gene. Next slide, please. So in regards to what the current guidance says, and it's the Prostate Cancer Risk Management Programme, that guidance is, we feel, widens health inequalities, because what it's saying is that it is available and free to any man aged over 50, but they have to request it and they have to know that it's available for them. So for men where health literacy, access to information isn't necessarily available, then that is broadening and certainly making that health inequality wider. So what we would recommend is focusing on men who are at most risk, and those are those 3 age categories, looking at the ages of 45 for those 2 high risk categories of Black men and family history, and then capping it at 70. We advocated this approach for the PCN DES. Next slide, please. So this is a pathway that we've been really embedding with a number of primary care networks, cancer alliances, ICBs nationally. We've been having really fantastic conversations with leads about what they can do to really help raise awareness about risk to prostate cancer, but then also have those proactive and opportunistic assessments of men at risk. I appreciate the text is really small on here, but the resources will be shared with you as well, so you will be able to access it. But I'll very quickly run through the content. And the pathway is essentially looking at creating better efficiency and a better experience for men when they access healthcare. So first of all, it's about identifying your target group. So those are those 3 risk categories which I mentioned before. We've provided some exclusion criteria for you as well, so that helps with being able to make sure that the right men are targeted. And then we would advocate that a champion is assigned to deliver on this work. It can be a member of your admin team. Sometimes I know that there are social prescribers, there are cancer champions who will be able to do this piece of work. And what we'd recommend is sending batch messages so you don't overwhelm your systems. And I'll share some results with you later, which can really help reassure that secondary care will not be overwhelmed with this work either. It's really important to make sure that the team who are answering phone calls and triaging men in the first instance are aware of this pathway, because there will be asymptomatic men who will be contacting the surgery asking for a PSA blood test. And essentially what the programme is sending text messages to your cohort of men at risk, and it's embedding our risk checker, which is a 30-second online tool which essentially provides accurate and up-to-date information about a man's risk, but then also goes through those pros and cons of the PSA test, and that's what the guidance asks for GPs to do. So it's essentially the equivalent of a GP counselling appointment. I think the thing which we really like about it is it provides the whole A to Z of the pros and cons, and it does it in a very unbiased way. So it provides true informed consent and decision making by that patient. And we've also provided a SNOMED code for you as well to be able to help with auditing process. Next slide, please, Lucy. Thank you. So that pathway was developed as a consequence of working with the Bristol Primary Care Network a couple of years ago now then. So you can see the sample text message there, which I won't read out for the purposes of time, but we have, again, all of that information on our website. They identified those 3 cohorts of men at risk. They started off with their Black population. They were an inner city PCN with high deprivation. So they started with their Black men first, and then went to their family history, and then targeted that wider group. You can see that over 2,600 text messages were sent. Now, bear in mind that this was over a 6-month period, so it wasn't all in one go. So again, systems weren't overwhelmed. Now, the interesting thing here is just over 900 risk checker completions were made from that cohort of men. So in terms of risk awareness, absolutely fantastic. More men are aware of their risk, and they're aware of what the test is, because of Jeff alluded to as well about the DRE. There's a lot of sometimes fear about coming to the GP, because a lot of men think that the first and only test is the DRE. So this helps to break down that barrier. Over 500 PSA tests were booked. So again, a really positive engagement with the text messaging and coming into primary care. Out of that 542 cohort, there were 16 referrals made into secondary care. So you can see that the right men were being put into secondary care, and out of those 16 men, we know so far that 4 men have been diagnosed. So it's a significant number of men who are being diagnosed once that risk stratification approach has been taken. Next slide, please. So the ICB in Hounslow have been working with their PCNs and been delivering on a piece of work from October, and the work is going to be finishing in March of this year. And what they've been doing is they've been looking at targeting those 2 highest at-risk categories, and they've increased their age range to be men from the ages of 45 through to 75, and they also have had an inclusion criteria. What they were going to do with their patients and have been doing is that all of those patients who fall within that age, those two categories, must have a documented discussion about the pros and cons of the PSA test, and so that would help to enable them to make an informed choice about having the test. And then the other piece of work which all practices were commissioned to undertake was to promote the symptoms of prostate cancer in high-risk patients as well. As I mentioned, there was incentivisation to that programme, and they also provided some SNOMED codes as well to be able to help with that auditing process. Next slide, please. Thank you. So finally, you may well be aware of Prostate Cancer UK's incredible screening trial, which will be launching later on this year. It's a significant amount of money which is being invested into this trial, which we're really proud to say is in conjunction with the NHS, the National Institute for Health and Care Research, and the UK government, as well as leading lights, leading researchers internationally who have put their brains and minds and energy to putting this trial together. So we're going to be recruiting literally hundreds of thousands of men, and that will be looking at what tests are available and providing definitive evidence about the best way to be able to screen for prostate cancer. So when will it start? We are looking to start setting up the trial in spring of 2024, so do watch out for some updates. And we'll be starting to recruit men later on this year. So if you as a PCN or as an area are really interested in being part of that trial, then please do get in touch with us, and I will be able to join some dots for you to be able to help facilitate that conversation. In regards to the test, sorry, Lucy, just very quickly, you can see the information here on the test, about the test. It will be looking at different diagnostic tests, and then also the age range as well. And I think the interesting thing with this trial is that we will be focusing on black men aged between the ages of 45 and 75, and targeting 1 in 10 black men to be invited. Thank you.
Hi, I think it's over to me again. So we can touch on some of the questions within the chat as well, and it's nice to have this as an interactive session. And also we can have a brief chat about the Transform study, and that in itself would potentially try and answer some of the questions that are in the chat. But it's good to have an understanding of where we've come from and where we are now, and that hopefully will answer some of the or alleviate some of the worries we have around testing men with PSA, and actually alleviate some of the worries men have about the harms that can potentially come from a referral into secondary care. So let's say we've put 2015 down, but really going back, 5-10 years, any man who was at risk of having prostate cancer would have a PSA blood test done. About 16%, so 1 in 5 would have a raised PSA. All of those men would go on to have a biopsy. So if you had 1,000 men with a raised PSA, almost 1,000 men would have a prostate biopsy. This is an invasive test, and it was done at the time transrectally. It was done with an ultrasound, but you can't see prostate cancer in an ultrasound scan. So what we did was we essentially placed the needle into areas we felt that cancer commonly occurred. And we did this about 12 to 18 times, depending on the types of biopsy we're having. And unsurprisingly, it meant that most men who had a transrectal biopsy actually had a negative biopsy, so almost 3 out of 4 men. Some had quite significant side effects from a prostate biopsy, including sepsis, very rare, but death, but actually bleeding in the back passage, problems with passing urine, retention. There are a whole host of problems with a prostate biopsy and a transrectal biopsy. And we also had problems characterizing the disease accurately. If you can imagine, within the prostate, a prostate cancer normally is not huge. It doesn't take up the whole prostate. It doesn't usually take up even half of the prostate. It's about 1 centimeter, probably is the most common size of the cancers we're seeing. And we're passing a needle into this organ randomly. So we might get lucky and we might go straight through it. Brilliant. But equally, there could be a very small cancer and we go straight through that as well. And suddenly we think this is a lot of disease. Or we miss it completely because, well, prostates, let's say, usually 4 or 5 centimeters across, and we just happen to miss it between these needles that we passed. And so we falsely reassure a man. Or we just skim this lesion. And we say that, again, falsely reassure or occasionally falsely diagnose a more aggressive disease. And so we weren't very good at characterizing the disease. And actually what it meant was, because we didn't know, we weren't confident in our test, we ended up over-treating a lot of patients. We could only offer them aggressive treatment because we weren't really sure what was going on. And the data would support that actually 50% of prostate biopsies done were mischaracterized. So a lot of patients. And this all changed through a lot of research that came out of a lot of London institutions, including Imperial, UCL, and this was to do with MRI scanning. The first time we had a test that would allow us to actually see these cancers. And a bit later on, I've got a picture to show you what we actually see when you refer a patient into us. And what it meant was that now a patient who has a raised PSA, and it still will be about 1 in 5 men will have a raised PSA if you do one, if they're asked to do one, they now go and have an MRI. The clinical trial data suggested that if we used this as a triage test, so only biopsied men who had an abnormal MRI, we could probably save 1 in 4 men from having a biopsy. Our real world data actually suggests we're probably running it closer to 1 in 2. So about 40 to 50% of men potentially can avoid having a biopsy altogether and be discharged back into primary care. We're also, because we're doing fewer biopsies, but because we can see the disease, we're also now making a much more accurate diagnosis. We're picking up very little low-risk disease. Most of the disease we tend to pick up tends to be significant cancer that needs to be treated. Again, it means that we're now offering appropriate treatments to men when we diagnose them, rather than just a blanket treatment for everybody because we weren't sure what was really going on in their prostate. So there's been some big changes that happened over the last 5 years in terms of prostate cancer diagnostics. The other big one is the use of transperineal biopsy. I have to admit, it is probably a little bit more uncomfortable than our previous transrectal biopsies, and it's just the fact that the perineum has got more nerves than parts of the rectum. But it is much more accurate and has an almost, it's never going to be 0, but it's an almost 0% rate of sepsis. And the slide says 40%, but in Northwest London, I can't think of a centre still doing transrectal biopsies. Almost every hospital in our region has transitioned over to transperineal biopsies. So that's been another big change in what's happened in terms of our diagnostic pathway. Next slide, please. And PSA. PSA has its pros and cons. It is, I think, sometimes misunderstood as a test. It has a lot of negative press. In reality, I personally think it's not a bad tool at all, as long as we understand what it means. The risk of prostate cancer increases as the PSA goes up. So someone with a PSA of over 20 has an almost 100% chance of harboring a prostate cancer. Equally, someone with a PSA of less than 1 has, again, as I said, it'll never be 0, but an almost 0 chance of dying from prostate cancer within their lifetime. So actually, high and low values are very useful. What we struggle with is with a lot of the values in the middle. And in that setting, PSA alone often can't diagnose cancer. But previously, it also caused problems because we had no additional test. And now at least we have an additional triage test before a man ends up getting a biopsy. There are a few things I think we all need to be aware of about PSA and what you do before you touch someone. It obviously goes up with an enlarged prostate. It goes above, it increases with aging, but it also goes up quite a lot in patients who have a urinary tract infection. And we do see this a lot in secondary care, where we get referrals in for patients who've had a PSA done whilst they've got an active infection, or very soon after an active infection. And this causes problems because it can jump up sometimes quite significantly and stay raised for up to 2 months. The other thing that can actually cause PSA to jump, again, quite significantly, is ejaculation within the previous 48 hours. Or obviously if someone has a urological procedure such as cystoscopy. Exercise is an interesting one. The data would support that actually doesn't rise as much as we think. We normally ask men to not cycle or do vigorous exercise just before having a PSA, but it probably doesn't make as big a difference as we think. And equally, having a DRE done, unless it is incredibly vigorous, is very unlikely to raise your PSA significantly. So those two things wouldn't be exclusion criteria on my list, but they are often on a part of testing criteria. And the other thing is to try and get the result into the lab as quickly as possible, ideally within 16 hours. Next slide, please. And these are the new but old thresholds as recommended by NICE. So these are the thresholds we used about a decade ago, if not longer. They were established, I believe, in 1993 by essentially looking at it might have been a Canadian population and determining that PSA goes up with age. It's also related to prostate volume. So the larger a prostate, the higher the PSA. And they established these normal cutoffs, which are based around deciding how many men we investigate and how many we don't investigate for prostate cancer. These are new because we, for the last few years, have been following the cutoff of above 3 in men 50 and above, which was based on the prostate cancer risk management program. And that has changed slightly. But what's interesting is that these new NICE NG12 guidance actually recommend offering a PSA test to anyone who presents to your clinic with lower urinary tract symptoms, erectile dysfunction, which is interesting, or visible hematuria. And in reality, this will probably impact most of the patients you see with lower urinary tract symptoms, because visible hematuria usually triggers an immediate 2-week wait referral anyway. It also asks men to have a DRE, and we can talk about the pros and cons of it, but in secondary care, we don't rely on DRE that much. It is generally speaking quite a poor test for diagnosing cancer. So for most of the cancers we pick up that are localized, it doesn't help. We see plenty of patients and we examine them ourselves and see nodule on one side, but then the cancer's on the other side, or we feel nodules and there's no cancer. So DRE is only really useful when you have quite advanced disease, and that our data and multiple other data sets show that. So if you have locally advanced, so quite an abnormal feeling prostate, that's usually diagnostic, but most small little nodules often come back as negative or benign. Next slide, please. And this is the referral form. I think you've all seen this before. The main thing I just want to stress is the bit about UTI, because the referral form still says PSA and have excluded a PSA above age range, and a UTI has been excluded, and there's at least 8 weeks after. And the reason you'll see why this is important is now on the next slide. And it's because of the faster diagnosis standards. So this is a target that we have to meet from the minute a referral is received into secondary care. And we have 28 days to give them a diagnosis of cancer or no cancer. And if you can imagine that we have a patient who arrives to us with a urinary tract infection in the last week and a raised PSA, that creates significant problems for us because we have to wait 8 weeks before we can even repeat that PSA. So often we do end up having to discharge them back. Or equally, if we have patients who've not had a urine done by the GP, we have to then organize for the patient to come in, have a repeat urine, get the urine test, book an appointment to review, and it adds time. And we're fortunately under pressure to try and get this pathway done quickly. We can debate whether that's right or wrong, but that is the reality of what we face. And similarly, blood tests as well, because we're now trying to get patients straight to test, knowing that they have normal renal function is important. Equally, knowing whether they're on anticoagulation or they have significant family history is also quite important. And what almost all the centers are trying to do is to triage the patient, whether it's virtually with a telephone call or without even calling the patient, straight to an MRI scan. So if they meet all the criteria, which is that they don't have any metalwork, so we know that they don't have a pacemaker, we know they're not on any anticoagulation, we know they've not had any infection recently, we can take them straight into an MRI scanner, which means we can really speed this pathway up. And then we can review them afterwards and decide whether they need a biopsy or not. And roughly speaking, about 50%, the numbers fluctuate. But roughly speaking, about 50% of men who have an MRI will end up needing a biopsy, and the other 50% will be discharged. And in some centers, we can actually do this on the same day. So actually, we can do the MRI in the morning, and if need be, do the biopsy in the afternoon. Next slide, please. And the next two scenarios are interesting. This is really, again, to try and get discussion, and I'm happy if people turn on their mics and ask questions or put their hands up. And it's just a couple of scenarios to try and gauge what everybody would do and what you all think about these cases, because I suspect they are relatively common cases coming into secondary care, into primary care. So the first one is an 83-year-old man, white man, no family history, who presents with nocturia, negative urine dip, but has some in his past medical history has ischemic heart disease, bit of CKD, is diabetic, and also suffers from COPD. And the question is, what would you do? What would be your next step for this patient? And I think there's a poll on the screen, so I'll give it a minute or so. There are 76 people on this call, and I count 25 responses.
I think there's some issues with people being able to submit a vote if they've got an organisational email. So
Okay.
we'll see. Maybe people can put their answer in the chat if it's not
So,
working.
I mean, I think there's enough now to get a confidence interval around the voting. So we've got two that have basically come out almost joint. So one is PSA and DRE, and the other one is a LUTS assessment. Is it possible to remove the poll from the screen? Or I can close it myself. There we go. So it's an interesting patient. According to NICE criteria, we should be offering this man a DRE and a PSA. But he's actually presented to you with LUTS, so the answer is not clear. It may be more than one thing, and he's asking whether he potentially is asking whether he should have treatment for it. And before doing a PSA and a DRE, or at least doing a PSA, we're being asked, or GPs, you're all being asked to counsel the patient on the pros and cons of a PSA, which I think it probably not always straightforward. And my take on this patient is that he's 83. He's got significant comorbidities, and we have to take into account performance status here. If these are significantly impact on his general quality of life, and you do a DRE and you may feel a small lump, that's fine, but it doesn't feel particularly abnormal, there is an argument not to do any further prostate cancer testing at all. Because what we're up against in this man is his life expectancy. The average life expectancy in the UK is around 80. If you get to 80, you probably don't have another 30 years to live. And someone with cardiac disease probably doesn't have 10 years to live. It's difficult to gauge this, but these are the sort of questions we need to take into account. And if we diagnose prostate cancer, even if we don't treat it, a significant number of these men will actually die from other causes. So we have to take all of that into account when offering someone further testing, because it may mean we go down a path where we do further imaging tests. And an MRI, I've been in a scanner, it's not the most comfortable thing to have done. It's nice, and men, we've done a lot of focus groups and a lot of work on this, and men would definitely prefer an MRI over a DRE or a transrectal or a TP biopsy, but it's still not the nicest experience. And then some of those will, because they've now entered this pathway, will end up having a biopsy. So that would be my take on this, would be to probably assess the LUTS. And nocturia is a difficult one because it is actually often related to non-urological causes. If it's an isolated symptom, they're related to sleep apnea, it can be related to kidney disease, it can be related to cardiac disease, peripheral edema, and then occasionally can be related to bladder outflow obstruction or overactive bladder. So personally, I probably would have managed that and then had that discussion. But what does everybody else think on this? There are a few hands that went up.
Yes, this is Dr. Ahmed. When you try to do, for example, PSA, it does come up with a pop-up saying, do you think that this patient has a life expectancy of 10 years beyond your test? Now that really puts us into rather a quandary. And I understand that you've gone through some of the issues here, for example, the ischemic heart disease and COPD and CKD3 that this patient has, and the age. So I try to avoid, and the other thing which I was going to ask you is that we asked to do both PSA and the DRE. If you do the DRE, then previously the perceived wisdom was that it really raises the PSA or changes the level of PSA. So, either you do the PSA beforehand if you want to do it, and then do the digital examination, or you forego the PSA, just do the digital examination. I'm not really certain how to get around that.
No, it doesn't. So I agree. On your first point, I agree. There's a lot of difficulty in determining someone's life expectancy, I think. So we have to take into account their wishes as well. But generally speaking, men in their 80s probably don't have that long to live. If he was obviously fit and well, had no medical issues, ran a marathon the day before, I think that's a different sort of patient. But someone with diabetes, ischemic heart disease, probably metabolic syndrome, is not going to be our fittest patient. And then you've got to also think, what's the benefit of doing anything if he's asymptomatic from this? So again, if this patient had back pain, bone pain, had some other red flag symptoms that were making you worry, that's an appropriate reason for a referral. And again, if you refer this, we would still review them. But in a completely asymptomatic manner, we've got to think what's the benefit. And the median survival for someone with metastatic disease is 5 years. So on average, men that we find with newly diagnosed metastatic cancer live 5 years at least, and half will live longer. So the general outcomes, even in the worst scenario, are generally quite positive. In terms of your second point, DRE, we no longer worry about the small rise that happens with a DRE. It's usually never going to be enough to change your management. If it goes up a small amount, unless you're sitting right on the threshold for referral and no referral, it's not going to make a difference. And generally speaking, it doesn't rise a lot. So I wouldn't worry too much. I would just do the DRE. It doesn't need to be overly vigorous, as I said, but I would do both. I personally, as I said, in secondary care, we actually, because we now have MRI, we tend to do very few DREs anyway.
Yeah,
and actually, all the patients you refer to us with an abnormal DRE, we just scan. We don't repeat the DRE.
So should we be doing the DRE in general practice if we got suspicion?
It's part of all guidelines. I wish they would remove it, but it is there. And there is, as I said, if the positive predictive value, so the chances of having cancer, if you think it's locally advanced, so T3 disease, which is usually quite abnormal, is pretty high. So if you did it and you felt this feels really wrong, you're right. It probably is going to come back as quite an advanced prostate cancer. But if you feel a generally smooth prostate, or you feel a small area that's a bit irregular, or a little bit of a lump or a nodule, often you can't say whether that's cancer or not. So there is still some benefit there. But I offer it to men and say, if you say no, it doesn't bother me.
Sorry.
What is interesting that we sometimes get patients with a DRE only without a PSA. That does create a lot of problems for us, because we then have to get them in and do a PSA, because actually once we start doing something to them, that's when their PSA will be inappropriately raised. So we do need a PSA with a referral, but we do see them sometimes. I'm not saying from this group, but we do see those referrals.
Just mindful that we've got 11 minutes left.
Oh, sorry, I didn't realize I can talk forever.
No,
so next slide.
Totally fine, because it's
next slide. So
yeah.
So
but I think some of the stuff that people have been asking about in the chat that we haven't addressed will be sent around as some of the pack resources. So if we don't get a chance to get around to everybody, it will be.
We're almost at the end of the talk anyway, so I'll do this quickly. 55-year-old black man this time. He is diabetic, positive family history, brother had prostate cancer, but presents to you again with LUTS, but this time frequency and urgency, and has some sugar and so glucose in his urine dipstick. His PSA has gone up from 0.9 18 months ago to 3.1. What would you do? We've got about 20 responses, and most of them are landing on one answer. So an interesting one. It can go either way. Most people have said they would send in a 2-week wait referral. There's two bits to this. One is this: he's obviously high risk. So one, being a black man makes you high risk, and then on top of that, you've got a positive family history. So he's already high risk. His PSA has gone up. The issue is, have we ruled out he's not got a urine infection? And that would be my main thing here, because that urine infection could cause that PSA rise. And if you did find that he had a urine infection and you treated it, his PSA could normalize. And then that opens up a different question: should we be screening all men with a normal PSA who are high risk? And that's a completely different argument. And that's the sort of thing that Transform trial will hopefully try and answer. So if we saw this in secondary care, what we would do is we would perform an MSU first. So now, assuming you've done an MSU and it's negative and his PSA has gone up, then that makes it much simpler for us to see when we take that referral. We just can't. It's actually, we can give potentially quite a life-threatening infection if we biopsy someone in the midst of a urine infection. Any comments there? There's one question about MSU, even if no leukocytes or nitrites. Yeah, it's a tough one. I mean, if both of those are negative, that's got a relatively high NPV for any underlying infection. So if you sent it, it's helpful for us to at least know that it's definitely clear. We do occasionally see asymptomatic bacteria, but I take your point that if it's completely clear, then it is going to be less likely. Next slide, please. And there's a few questions we can pick up at the end. So as I've said, when they come in, we triage, and they will end up usually having an MRI scan plus or minus a TP biopsy. Next slide. And yeah, so this is what I wanted to highlight. The image on the left is what a prostate looks like on a CT scan. It's this non-specific homogeneous mass that sits just under the bladder. We have no anatomical descriptions, landmarks, and we can't really see anything at all. And actually, it doesn't look that different on an ultrasound scan either. And you see the image on the right, same patient. That's what we see on an MRI of a prostate, compared to our traditional imaging was a CT and ultrasound. And that's the difference that this is all made. If you can imagine, that's the size of the prostate, and I randomly sample it 12 times, there's a very good chance I might miss that. But now we can aim at it and take some core straight out of it. And this is what's happening when they come into the hospital. Next slide. And this is essentially just a summary. So I still think PSA is a good test. And the key here is it is still our only available first test to go down the pathway for diagnosing prostate cancer. We have no currently validated or cost-effective alternative to PSA. And that's one thing we need to remember. So if someone is worried, then we have to do a PSA. And if we understand the pros and cons of it, it's not a bad test. And now with MRI, we also have a second triage test that helps us to try and minimize some of the harms that go with coming into secondary care. Ethnicity is very important. So black men are at much higher incidence, much higher risk of developing prostate cancer. Family history is very important as well, and particularly if you combine multiple risk factors. So black man with a family history is significantly higher risk, more than 2 times. So each additional family member increases that risk. So 2, 2.5 to 3, 3.5, 4, it does increase. And one thing I've seen, and it was quite worrying to see this, it doesn't happen very often, but I was at a patient engagement event, and the wife, sorry, the sister of a man who had prostate cancer stood up and said, my brother had prostate cancer, I've had breast cancer, my sister's had ovarian cancer, my 3 other brothers, their father have all had these illnesses. And I said, well, have you guys ever been for genomic counseling? And she said, no one's ever asked us our family history. So there's probably a few pockets of quite high risk disease going around, and I think we have to ask and actually draw that family tree to see what risk they're at. UTIs, I've stressed quite a few times, so I'll leave it. DRE, we've had a discussion about, and red flag, I think you're all aware of these. It doesn't necessarily mean they've got prostate cancer, but red flag signs, significant weight loss, back pain, any signs of cord compression, these things just need to be blue lit into a hospital. And usually we've got on-call oncology who will often pick them up and manage them. And I think that's the last slide. So next slide, please. Lots of resources. We'll send all of this information around. Next slide. And that's it. So thank you. And I've left us 5 minutes for questions. I'm really sorry.
Yeah, wonderful. Thank you so much, Tamer. That's really helpful. Sorry, I'm another Lucy, but I'm Southwest London Lucy. We've met Northwest London Lucy already. There were a few questions that were slightly earlier on. I'm not sure, Tamer, if you wanted to touch upon any of them in the few minutes that we've got remaining. We've obviously touched on PSA already. There was 3 questions from Daisy Lund. Just with regards to one of them about DREs in patients with normal PSAs, and also about a question about why incidence of prostate cancer is increasing, and also a question about dairy intake being a risk factor.
So pick up that last one first. So yeah, the incidence is increasing. There's obviously environmental factors. So different populations, when they move environments, start to get higher incidence of cancer. So there's obviously some environmental impact, and there'll be dietary impacts, but it'll never just come down to one simple thing. And I'm not aware of dairy, but I'm sure there's going to be epidemiological research out there. And if you've seen that, then it's worth looking at why, what the link is. But my understanding is there's never any one specific cause. People often ask me about dietary changes. There is never one factor that is so strong that it'll predict someone getting prostate cancer. Vitamin D might be protective. A diet low in animal fats might be protective. Obesity might have a negative impact, but it's not as if all obese patients get prostate cancer or other cancers. These are all incremental things. So I suspect there will be something there, but by itself, it won't explain everything. What was it? DRE in a patient with a negative PSA? Yeah, it's an interesting one. If your DRE is only slightly abnormal, what do you do? We see a few of these and we scan them, and they often come back negative. But we know that the reason the Transform study is being opened is because we have preliminary data that was run through Northwest London showing that MRI is actually potentially a better screening tool than PSA. So MRI will find cancers in patients with a normal PSA that are potentially significant. And that's part of why we have a screening trial because our national screening committee has said PSA alone is not good enough to screen because of some of the harms, but potentially using MRI instead of PSA might reduce a lot of those harms. So in all honesty, if you're worried, I would just say send in the referral. We're fine with that. But often they don't have cancer. What are the other questions? High risk patients with an infection, it's still worth treating it and seeing what the PSA comes back as. Just being high risk alone doesn't mean you have cancer. Most men won't have cancer, and most men won't develop cancer in their lifetime. We just need to be aware that this is a patient that you shouldn't forget about. So if they do have a UTI, they definitely need to have a repeat PSA. They definitely need follow-up, and some of them will need to come in to see us. So the key is to just not forget about them. Problem is we can't do anything if they've had an active infection for 8 weeks. And so sometimes we do end up just having to discharge them back, which just unfortunately then creates extra work for everybody.
And there were just a couple of questions that just came right at the bottom that we can maybe just touch on quickly before we close in the last minute, if that's all right. So about what constitutes the Asians in terms of the 1 in 13 risks? Is that all Asian ethnicities or more specific?
Yeah, Indian subcontinent.
Okay, wonderful. Yeah. And then someone else also put a question about PSA velocities as well, and when to refer having excluded UTI.
I think it's a tough one. So if you're above the age-specific cutoff after a UTI, I think refer it in, because what we would do is we would do the MRI scan. If the MRI is negative, we will then hopefully discharge with an appropriate cutoff. There isn't one. we talk about velocities of 0.75 nanograms per milliliter over a year, or a rise in however many percent, but none of them are perfect as tests. So it's just about having a next sensible level, and essentially you need to refer them in. Now, if someone's got a PSA of 4, then it might make sense that next level is somewhere between 5 and 6. If someone has a higher PSA, then you maybe want to set a slightly higher boundary. These small changes in PSA may seem big when you look at the velocity, but in reality, they don't usually impact survival, and they don't usually impact the severity of disease. So you're not going to suddenly miss someone with raging cancer because of you've been worried about a small rise in where you should set your upper cutoff. So we tend to set it based on volume. So if we know that, because on MRI we can get an accurate prostate volume, we can set a cutoff based on that. So small prostates with high PSA make us worry. They either have significant inflammation or they're likely to have cancer. Big prostates with low PSAs actually have a very low risk of having underlying cancer. So we can adjust that based on volume and send it back into the community. And similarly, if someone's had a biopsy that's negative, we can again send the patient back with an appropriate cutoff.
Great.
I hope that answered the question. It's a bit, I haven't answered it completely, but it's because there isn't a correct answer. So just something sensible is reasonable. And if it's risen and you're worried, then again, send them in. And we talk about doubling times, but it's rare that you're going to see in the community a doubling time of less than 12 months. That's when you start to get worried that the patient might have metastatic disease. So if the doubling time is normally for most prostate cancers is usually a few years.
Wonderful. Well, thank you so much on behalf of all of us for a really, really helpful, informative and also emotive discussion on prostate cancer. Thank you so much, Jeff, for coming and giving a patient perspective, which we don't often get on these sort of forums. So really, really thankful for you to have the courage to come and speak to us today. And thank you for the wonderful discussion that's been generated as well. So yeah, on behalf of all of us and on behalf of RMP, thank you very much, everyone. And we'll let everyone get back to their day. But thank you very much.
Thank you, Mr. Shah. Thank you, Jeff. Thank you, Lubna.
Thanks, everybody.
Thank you.